Welcome to the December 13th, 2023 regular meeting of the Washington Township Healthcare District Board of Directors. I'd invite you all to stand with me and join in the Pledge of Allegiance. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. Thank you. Public notice for this meeting has been posted appropriately on our website. Tonight's meeting is in person in the boardroom at 2000 Maury Avenue, Fremont, and is also accessible by Zoom. I ask that you mute your systems until such time as you need to speak. Tonight, we are recording tonight's regular session of the board meeting. You will be reviewing. What are we doing? We okay up there? All right. I'll try again. Cheryl, would you please take the roll?
Yes. Director Stewart.
Present.
Director Wallace.
Present.
Director Nicholson.
Present.
Director Yee. Present. Director Epen.
Present.
Thank you, Cheryl.
You're welcome.
I'm going to take communications slightly out of order tonight. I'm going to move to that first. And that is the oral communications, where members of the public are invited to speak. When prompted, please state your name for the record, then proceed with your statement not to exceed 3 minutes on issues or concerns not on the agenda but within the subject matter jurisdiction of the board. We have with us tonight representatives from CNA. This first group is going to be speaking. Evie Merritt.
She's right behind you.
We'd invite you to stand here.
Thank you very much.
You guys could stand if you'd like, whatever you'd rather do.
Hello and good evening. My name is Evie Merritt, and I am a member of the bargaining team, and I've been working at Washington Hospital for nearly 7 years. I am here tonight not only on behalf of the bargaining team and the nurses that work here at Washington Hospital, but also on behalf of the patients that seek care here. According to the Washington Hospital mission statement, this facility is committed to a culture of patient safety and accountability, as well as providing access to high-quality, cost-effective healthcare services through an integrated delivery system. I would like to ask, does floating nurses to an area outside of their highly specialized unit to make up for a lack of retention in other areas qualify as a high-quality integrated delivery system? Does the float language presented by management to the union promote a culture of patient safety and accountability? Additionally, I would like to pose the question, does this hospital and the board of directors value this community's nurses? Does the hospital strive to maintain nursing excellence as outlined by the Magnet Designation Program? If the answer to my question is yes, I implore the facility to provide an economic package representative of our nursing excellence, the difficulties we at the bedside have faced throughout the pandemic, and efforts to maintain and strive towards trauma status. Based on information taken directly from the CEO's employment agreement contract, the CEO has received a salary increase of over 34% over the last 4 years, not including bonuses paid, the monthly auto allowance outlined in her contract, or reimbursement of expenses. While I will not claim to know all of the details of the CEO's responsibilities, which I understand are great, I pose another question. Are the wages outlined in the hospital's economic package on par with the wage increases allotted to the CEO and all other executives? I'll answer that question. No, they are not. Not only that, but the changes proposed to our healthcare benefits would cause our deductibles to increase by up to 200% annually. We at the bedside have faced nearly insurmountable difficulties in recent years. According to an article published by Reuters in May of this year, over 30% of bedside nurses in the United States are looking to leave the bedside, according to research, which is an increase of 7 percentage points since 2021. The key to continuing to provide excellent patient care and provide safe staffing is recruitment and retention of both new and experienced nurses. I fear that with the changes proposed,
30 seconds.
The hospital will not only fail to recruit, but fail to retain the nurses currently employed. I love being a nurse, and I came into this profession to take care of others. And I have taken care of people on their worst and sometimes their last days of their lives. And I want to work somewhere where I feel like my work matters. And I want that place to continue to be Washington Hospital. I urge the employer to do the right thing, make nurses feel important, valued, and appreciated, instead of making us feel like we are just another cost to be mitigated.
3
No
minutes.
no takeaways, it's their contract. Thank you. Thank you.
Thank you very much, Evie. Thank you all for being here tonight. As you're aware, there's a large group of you to come in and make presentations. We appreciate you being here. We appreciate your message. But at this point, we're going to change and let the next group come in. Thank you again.
Thank you. Thank you.
Always have Kate, right? What? I said nurses always have Kate.
Okay, thank you. Thank you all for coming. As you're aware, we're doing 3 groups tonight. You're number 2, and we appreciate you coming. We're going to listen first now from Kim. Thank you, Kim.
Good evening. My name is Kim Lake, and I've worked in the Birthing Center for 30 years. I currently serve as a bargaining team member, this being my 3rd time doing so. It's been my privilege to be a nurse rep since 2015 and to serve as the chief nurse rep for the last 5 years. The position has afforded me the opportunity to talk, and more importantly, to listen to nurses throughout the organization. Tonight, I have 3 issues from the nurses to bring to your attention. First, some old business. On August 21st, we presented you with a petition regarding postpartum ratios in the birthing. Nurses of the Birthing Center have let you know that we are concerned the change from 1 nurse to 3 couplets to 1 nurse to 4 couplets will jeopardize the health and safety of our patients. We again asked for a response to this petition on October 25th, and we are disappointed that we have yet to receive that response. Secondly, nurses worked on the front lines through mass amounts of uncertainty during the COVID pandemic. We worry about keeping our patients, our families, and ourselves safe during this time. After all we've been through, it is difficult for us to consider changes to our health insurance. Most Washington Hospital nurses use the current PTO plan because we do not live in Fremont. We live further away where housing is more affordable. We depend on this PTO plan because if we or our families need immediate care, Washington Hospital is just too far away from our homes. And the proposal presented to us The Tier 2 PPO would triple our nurses' deductibles and substantially increase the out-of-pocket maximum. I personally use the PPO coverage of our healthcare plan, and the thought of having to pay 3 times the amount to reach a deductible makes it difficult to feel my work here is valued by my employer. I came here today to emphasize our stance of no takeaways to our healthcare plan. And finally, as our negotiating team continues to bargain for the strongest contract possible, we demand the following. We demand that Washington Hospital Administration withdraw all proposed takeaways to our union contract. We demand that we reach a settlement that improves patient care, safe staffing, improves working conditions, and provides economic security so that we may recruit and retain dedicated nurses to provide the highest standards of patient care. We, the undersigned Washington Hospital nurses, stand united and pledge to take any actions necessary and to fight for as long as it takes to win the strong union contract our members, our patients, and our community deserve.
Thank you very much, Kim. And, again, we appreciate you coming, appreciate you all being here. I like the red masks. We appreciate you being here. We have the other group yet to come in, so we'd invite you to trade out with them. Again, thank you for being here.
Thank you.
Before we get dismissed, I made a quick poem. I was wondering if I can recite that poem. It's regarding all the units, if that's possible.
You should come up to
Want to do
the...
that with the next group? That way the other group can come?
Yeah.
I can definitely do that.
Yeah.
That'll work.
How do you want
Card.
He needed a speaker card.
Oh, actually, I have now.
Okay.
We have the speaker.
Oh.
I see if he's speaking.
Yeah.
Okay.
He doesn't.
Just name.
I know, just ask him first.
Nor. It is Nor.
Okay.
N-O-O-R.
Okay. He's getting it. Okay.
What's that?
The band is supposed to be being banned.
Well, I better buy them all now then.
We got a last minute.
Yeah.
So, and that's taking the place of the...
No, he's gonna say the
Hope
poem.
you're kidding, Al.
Yeah.
Recite the poem.
That's Nor.
Okay, so we're gonna hear both.
This will be the last two.
The contractual percent is 7.8 actual, and
Uh-huh.
the budget is like 7.
I check and see if anybody online wants
Yeah, I know.
to at the end.
Got to make sure anybody online, I'm sure we ask.
Keep coming in. Come on in.
After everybody's done here.
Sorry?
After everybody's done.
Oh, there are a lot of
here,
spots. Go ahead.
Before we end oral communications, ask if anybody's online that wants to speak.
We're allowed to sit on that?
Yeah, there's more room
Come
down
on
there.
in.
Please.
Oh, yeah, I want to sit by the board.
Yeah, yeah.
Big,
There's more seats. You want to come in? Oh. Oh, baby.
Oh, the mommy with the baby
Yeah.
and the kids. Okay.
There's room to stand over here. Come on in. Come in.
Good.
Saying that month's name.
You wanna sit?
Okay, welcome to all of you. As you've been aware, a lot of people, a little crowded, but we appreciate you coming. Appreciate you being here. And I have two speaker cards. I have one for Valerie and also one for Evie. Which is to go first?
It's actually, isn't it change?
Yeah,
It's gonna be Nora instead of Evie going, I think.
and I'm Valerie, so Nora can go first.
Nord.
Nor, yeah, NWR.
Thank you.
So, I'm sorry, I just want to be correct on this. So Valerie is going to speak, not Evie, and Nord.
Nor.
Nord.
I'm only gonna speak if, Nora doesn't use up the 3 minutes.
Oh, you can go.
Thank you.
You each
You
get
can do
can
3
do
minutes. Everybody gets 3 minutes.
Oh, okay.
Yeah.
We wanna hear from you too.
Yeah.
Nord, you're right. I got it right that time.
Esteemed members of the Board of Directors, Kim Agari, Larry, Dr. Nicholson, and the rest of the team, I stand before you, a voice echoing in the profound dedication and resilience embedded in the corridors of our healing institution, our Washington Hospital. In the realm where compassion and care converge, our nurses on 6 West, 5 West, 4 West, telemetry, medical oncology, short stay, 2 West labor and delivery, emergency unit, intermediate care unit, and ICU unit. They all have been unwavering pillars of strength, especially in the challenging time of the pandemic. And the echoes of the pandemic linger in the memories of our healing warriors on 6 West, where nurses are tirelessly committed to the well-being of their patients. Their stories are etched with sacrifice and unwavering commitment and resonate through the halls. On 5 West, a sanctuary of care and grace, our nurses have faced the post-pandemic challenges with resilience that time cannot erase. Their triumphs and cheers have been witnessed in the pursuit of healing, and they deserve more for the battle they have triumphantly won. The resilience that blooms on 4 West is a testament to the strength of our nurses. In the face of uncertainty, they persist with love that cannot be dismissed. Their dedication deserves a fair reward in countless lives they touch. In telemetry, where monitors hum, the pulse of post-pandemic healing, our nurses stand vigilant. Their commitment, unbound. Their quiet vows deserve recognition, fair compensation for the vital roles each one of them plays. In the medical and oncology unit, they house the warriors where courage resides. Even after the pandemic, they continue to guide patients through the storm of illness. The strength they exhibit deserves acknowledgement in the form of fair compensation. Through the transition in short stay unit, our nurses embrace the journey with
30 seconds.
Sum it all up. Emergency, intensive care, intermediate care. May we stand as stewards of healthcare. May we be recognized as an invaluable contribution that our nurses honor and their dedication with a fair compensation package throughout the years that they have served. Thank you.
Thank you.
Thank you, Nora.
Hi. Hi. I've been here 27 years. Next year it'll be 28 years. I just want to tell you thank you. Thank you so much because I am so honored to be a Washington hospital nurse. I love my job. I've been so lucky to work on 6 West with Lauren as my manager. I love Lauren. Every time I see Lauren, I usually give her a hug and I tell her I love her because I'm so lucky to be working. I'm very thankful to have powerful management as a woman, especially helping us in the hospital. And I just wanted to tell you thank you. So I don't have controversy to bring up or stress, but to tell you how lucky we all are to be here working with the patients in the hospital. It's the best part of my life, being here, working, taking care of patients. It makes me feel very thankful and have gratitude, and I thank God every day that I'm able to come here and work and take care of patients. And my work family, and my work management, also family. Thank you.
Thank you, Valerie.
Thank you.
Did I understand correctly that Amy wants to speak one more time?
No.
So we're done?
No.
I don't mean to-
Except for the folks online.
Again, we appreciate y'all being here. There's been a really, really large group of you here tonight. It's very impressive to see all of you together. And we appreciate you being here. We appreciate your work at the hospital. And it's been good to hear from you.
Maybe before they leave, to see if there's anybody else that wants to speak online.
Good.
There are no chat requests at this time.
Just ask.
Chat requests.
Just ask, Dr.
Yeah.
Stewart. Just ask.
Are there any chat requests online that wish to speak at this point in time on the issue before us? Hearing none. Good. Again, thank you very much. Good to be here.
All right.
Have a good night. Have a good night.
Hope you guys get home.
Have a good night.
Thank you.
You're gonna need that.
Thanks, Larry.
Good to see you. Have a great night. Thank you. Yeah, I can't put on the speaker.
Thank you. There you go.
Locked on this one. I want to mess with the settings and then it. Thank you.
I'll check it and send the rest of it.
I know.
Thanks. Nice seeing everybody.
Good to see you too. Have a good night.
Yeah.
Thank you.
Thanks, Dan. Thank you.
Now that everybody's got their candy, we can...
Kind of weird, there was 2 kids that didn't have any, so I'm like, oh, what do you want?
Should have called for more.
I know.
Put your stuff away.
Cute little kids.
Right.
Come on.
Bring some on this way.
Okay, we're ready to proceed with our agenda. Cheryl, are there any written communications?
There are no written communications.
All right, then we've followed our oral communications and our written communications. We're now going to move back to election of officers. Every year in December, the Board of Directors has an election of officers for the coming year. So at this point in time, I would welcome a nomination of the coming year's elected officers.
Mr. President, I move that the Board of Directors approve the slate of officers as presented as follows. President, Jacob Epen. First Vice President, Michael Wallace. Second Vice President, William Nicholson. Treasurer, Jeannie Yee. And Secretary, Bernard Stewart.
Thank you. Do we have a second? We have a motion and a second. At this point, I would called for a vote. Cheryl?
Director Stewart,
Aye.
Director Wallace,
Aye.
Director Nicholson,
Aye.
Director Yee,
Aye.
Director Epen.
Aye.
Okay. That motion passes. And so at this point, we're going to change seats.
Well, thank you, Bernie, for your work this past year.
You gotta move.
Okay.
In places, huh?
Yeah.
Good job, to sign.
Thank you.
I'm sure people watching would be confused otherwise.
Right.
Actually, let's go ahead and trade these.
Oh, okay, yeah.
That's official.
Oh, look at the review.
Thank you. Proceed. We'll go to the consent calendar. We'll now move to consent calendar. The consent calendar consists of those agenda items that the board will approve with one motion unless either a member of the board or a member of the public wishes to remove the agenda item from the consent calendar. If any items are removed from the consent calendar, the board will take action on the removed agenda item later in the meeting under the action item heading for the agenda. Does anyone on the board want to remove an agenda item from the consent calendar? Does any member of the public want to remove an agenda item from the consent calendar? Hearing none. May I have a motion to approve the consent calendar item A through D?
Yes, Mr. President, I move that the Board of Directors approve the consent calendar, items A through D. Second. So just call for the vote.
Oh, sorry.
Director Epen,
Aye.
Director Yee,
Aye.
Director Wallace,
Aye.
Director Nicholson,
Aye.
Director Stewart.
Aye.
So next we move to the presentation.
Yes, we do. All right. I want to start by our first presentation. We have three presentations this evening. The first is a trauma update, and it's my pleasure to introduce Elwood Conaway, and he is actually here this evening, present in this room. I will give you a bio on him, and he is the Trauma Program Director. He joined Washington at the end of September. Elwood most recently served as a Trauma Program Manager and Trauma System Director of Nursing for the U.S. Army SATMO in Abu Dhabi, United Arab Emirates. Elwood received his bachelor's and master's degrees from the University of Maryland in Baltimore, Maryland. He obtained another master's from Liberty University in Lynchburg, Virginia, where he's also pursuing a Doctor of Philosophy in Public Policy. I do want to say that even though he joined us officially in September, he has been in many leadership and discussions with our clinical staff for a number of months before he officially arrived. So he was able to hit the ground running and when he landed here in September. So it's my pleasure to introduce Elwood, and he's going to be giving the trauma update.
Thank you. Good evening, everyone.
Elwood, I just want to say it's a pleasure to see you in the flesh. We've heard a lot about
Yes.
Thank you. It's a pleasure. No, it's good being
That's
here.
why I figured you should be actually here versus in there. They won't know that you're actually
Close the little
present.
box,
Yes.
yeah. So, he's controlling the slides. Okay, perfect. So as we start our journey into trauma, the way we designed this presentation is a really quick breakdown on the history of trauma, how we got to where we are and where we're going in the same process. Next slide. So if you're looking at from 1966, the original studies that came out, we began to look at trauma as a perspective in how patients are managed. The National Highway Traffic Administration was developed right around between 1968 and 1972. And purpose behind that was looking at an individual study. EMS was derived from that, in the number of casualties or people who fell victim or succumbed to their injuries related to motor vehicle accidents, which over time, and if you think about it, originally we didn't have rear seat belts. We only had lap belts when seat belts were first originated, and even for child safety restraints, that became a major factor. Evidence and research continues to grow over the years, and that's why we got to where we are right now. The last, and I'll jump all the way to 2016. 2016, commission was developed to actually look at preventable deaths. So the goal is preventable deaths. With preventable deaths becomes injury prevention, which is the most important part of trauma. We tend to look at the care, but what happens prior to the care starting is the key to success and survivability. Next slide. So as we began to look at the three books, it's actually a total of the current book is the gray book. The orange book was the previous book, which ended in May of 22. As we look at the books are an institutional commitment to trauma. Each book is developed over a series of 6 or 7 years in research and evidence, and I'll get to that in a couple more slides. And what it outlines is what is needed by each individual institution to develop a trauma program and meet standards. So each individual state and county can develop and be a trauma center, but everyone cannot be verified unless you're verified by the American College of Surgeons. With this comes ATLS. Dr. Steiner, who was an orthopedic surgeon, crashed his plane in 1972 in, I want to say, Iowa, Nebraska. His wife died in that accident. Himself, his kids was mortally wounded. He was able to get a ride to a local facility. What he discovered that the care was bad. And as an orthopedic doc, he then went to American College of Surgeons and said, hey, we need to develop a course. ATLS was born from that course. ATLS is typically taught to most emergency medicine physicians, as well as most generalized surgeons who don't do trauma, not boarded in trauma. Dr. Morrison, who will be coming as a trauma medical director, did his fellowship. He actually did his fellowship at Shock Trauma prior to my arrival, so we kind of came after one another. But he is double boarded in trauma surgery as well as critical care. Next slide. So if you remember BLS, you got the chain of survival. This is kind of the chain of survival when we look at trauma in particular. Bystander care. Stop the bleed, which is the new and most common outside training platform that we're using across the world. I spent time in the UAE. And we mix BLS and Stop the Bleed at the same time. So if you look at most places that have an AED, airports, malls, what really should be following that, it should be an AED and a tourniquet, side by side, because they should function as one collective group. Pre-hospital, as you move into pre-hospital actually has gotten better over the years. If you go back to the original report and looking at in 1966 and 1972 pre-hospital report, our EMS system has grown and evolved to a point where if you look at from now, from even 10 years ago, when it comes to MI, strokes, our EMS system is a lot more advanced. The education platform that the paramedics are using are a lot more intense than what they were 10 or 20 years ago. Hospital definitive care is the standard. But the goal is to get people before they get to start care prior to their arrival into the hospital, and that's the main point. When you look at early rehabilitation and recovery reentry, that's the missing piece for a lot of places around the world. And most trauma centers in the U.S. are not far from that either. Getting people back into the community as functional members of society, to get back into the ability to provide for their families, to be an impact in organizations. We always worry about the family, but we also forget about their employer. So if you're injured, you're impacting your family, you're also impacting your job and the organization itself. So it's a double-edged sword in the large impact that we have on society when someone's wounded or injured. Next slide. This is one of the most important slides. In trauma, so right care, right patient, right place, right time is a military concept that was derived, Larry knows it because he was responsible for it in Afghanistan, that we actually will move patients where they need to be. The importance of trauma is showing that the right patient is at the right place and that the facility has the capabilities. We had a case out of the country. Patient had a head injury. He got sent to a facility. The neurosurgeon could not do a head. He could only do backs. So the patient did do fine because we got able to get into another facility, but that's a delay in care and it's a disruption in care. So knowing the capabilities of each individual institution, where they're strategically located at within a geographical region, will increase outcomes in patients. All the data that we get goes into a trauma registry. The trauma registry crosses right now 596 facilities at a minimum across the U.S. There are no international trauma centers yet. Having said that, all the data points, which is a minimum of 314 data points to a total of a little over 1,800 data points for each individual patient, is extrapolated, pulled into the registry. What I typically do, I'll take all those data points over a 12-month period, develop a retrospective analysis of anything from injury patterns to ISS scores to outcomes, to include demographics. I'll use the demographics in this region, within the Fremont region, based upon information that I have from the hospital so far. Most male injuries are from birth until the age of 60. At the age of 60, females' injury patterns increase. Now, I'm not sure it's because we're just old and tired at that point. So, but beyond that, for the most part, female injury patterns begin to increase. 64 and 70, higher risk of falls and injury patterns itself. So all that is what we began to take, and that information we use to derive, to push legislation to political governments, to the community at large, to boards to say, hey, this is what we need to do. I've done it before out of the country to push pediatric safety. Here, it will be falls and safety. So I've been able to reach out to Alameda County and their resources to look at what we can implement in the community for fall safety, and I'll get to the geriatric program, which we're developing right now. Next slide. This is the history of trauma. RM's Cali started shock trauma in 1966, also known as the Death Lab. It was a 2-bed site in Baltimore in downtown under the coroner's office. Because most people, sounds bad, most people who were there were not doing well. They ended up going there over a period of time. What they discovered was that intense treatment and early intervention actually saves lives. The golden hour started with RM's Cali. From the point of injury to the point that a person arrives in the hospital is 60 minutes. Now, if a person is bleeding out, that changed the shift, that paradigm shifts. If not, anything longer than 60 minutes increases mortality in 90% of most patients. I use shock trauma because shock trauma was one of the first systems. In the 60s, there were 3 programs. One was shock trauma, the other was Cook County, Chicago, the third was San Francisco General. And those are the 3 primary trauma centers that existed in the U.S. The medevac system was federally funded, first in the state of Maryland, which is the model that was designed from Vietnam, and the implementation of the Huey and Black Hawk helicopters into combat for medical transport. The irony or the development that we take away from shock trauma is association of the NASCAR and the Formula One effect. The patient is always your car, is always your vehicle. The pit crew is the staff, to include your physician group. It is a organized chaos that gives outcomes. Everyone knows their job. It is a quiet roar, but everybody functions at a high level. Next slide. That's my twin brother. Dr. Morrison is actually the medical director. He's actually coming out of Saginaw, Michigan, Central Michigan, fellowship trained. So we're waiting for him. He'll be here January 6th. He was actually just left last week. So waiting for him, really ready to go. He's been on 90% of most of our calls since we started the program. Next slide. As we look at trauma centers, the Gray Book outlines 4 different trauma centers. I'm going to go backwards. Level 4, your rural communities. In Alameda County, there's only a level 1 and level 2s. There are no 3s or 4s in Alameda County at all. That is by design of Alameda County. But it makes logical sense the way that the county is designed. Your level 1 facility is your robust, your UC Davis, your Parkland hospitals, the University of Chicago, that has residency programs for everything. They have 24-hour in-house call, 24 hours a day. They have a minimum of 1,200 cases that they have to hit for admissions. That does not mean that they can have more. So the average facility has about 45% higher of people who are seen and treated and released than the number of admissions. ACS measures based upon the number of people that are admitted into the facility itself. The difference between a level 2 and a level 1 is the other part is research. It has to be peer reviewed, 10 articles per year from the service line, from each individual service line from a level 1. Level 2s are not required. Level 2s do not require a minimum of patients. Some level 2 facilities, I can know of a couple, they hit about 3,000 patients a year, and they're level 2, they're not level 1. So I'll pick on Mayo Clinic because it's Mayo Clinic. Mayo Clinic has a combined program. They see about 3,100 patients a year. That's peds and adults combined. So, and that's a low volume to be a level 1, to be both. So if you're a pediatric facility, you have to have more than 200 cases per year. We will not be a pediatric facility. We will see peds. We will develop a peds performance improvement process because anything greater than 100 admissions to the hospital is a mandate by ACS. But we have transfer agreements in place with Lucille Packard as well as Benioff to ensure that pediatric patients are transferred out of the facility to where they need to be to a higher level of care. In talking to Dr. Jensen, our primary goal here will be to stabilize and transfer. Next slide. So the question, when we think about the building of a trauma center, why are we building a trauma center? Are there lives lost? Can we actually measure that? The answer is that no, from a hospital perspective. Can the county measure that? Yes. They shouldn't be able to measure all deaths across the county. But is it trauma related? Really not sure, don't know. It'll have to be measured upon ICD-10 coding, and that will be a long extrapolation. What I can tell you, you had about 1,100 patients leave Alameda County to receive trauma care somewhere else. If you look at the time between Washington Hospital Center, Eden Regional, and Santa Clara, somewhere between 8 and 32 minutes based upon traffic and time of day. California has traffic, so 32 minutes is slow. So typically it'll take more than that. Having said that, we are already receiving patients or coming already. Even though our target date is July 1st, are we receiving patients? Yes. Why? Because we are a facility. We are an emergency department. EMS already know that we are going towards trauma, so therefore people have stopped in. People always walk in. One person actually was brought in by his wife with a single gunshot wound. I still think his wife shot him. But he drove in. His wife drove him to the hospital. The other patient was on their way to regional and actually had an airway compromise, therefore stopped here for management. Anesthesia stepped in along with the emergency department, secured the airway, prepared that patient, and transferred him out to another trauma facility. So that's the standard. Do we know the full impact? Well, we know the full impact not for about 12 months. What we do know is, go to the next slide for me. Go to the next slide. This is the map that's kind of the selling point. If you look where Washington Hospital sits at in the lower blue corner, the lower blue section of the map, all the level 1 facilities are across and in the bay, with the exception of Benioff and Highland. That's it. So if you're looking out further to the east, you have really no resources to the east. So by area location, we will be that primary center for everything in Fremont to include Union City and everything below. One, our relationship with EMS is stellar. Therefore, they will transfer and bring patients here. We have some of the best offload times in Alameda County right now. Therefore, people want to come. And paramedics enjoy, because paramedics also enjoy the conversation and education they're receiving from the department when they bring a patient. So that's a significant part. So space and location-wise, we are in a prime spot, in a prime location to meet the needs of the community. Next slide. So as part of trauma education, and simulation is the key to success. It is evidence-based, it is researched that simulation in particular is a significant part in the development of trauma. Just like in anything, the military uses simulation on a regular basis. That's how we train. We've trained for years with simulation. All the trauma centers, to include shock trauma, we use simulation. And also educational curriculums and courses, which is everything is expensive, of course. All the nurses, we develop curriculum for nurses, TNCC, advanced trauma life support for the providers, trauma care resuscitation for the critical care nurses. Then we just send people to a group of conferences that are existing within the Bay Area. Goal is to push people out to further conferences to get a larger, broader experience in trauma, but that's more to come. Myself and the education department right now, we are writing an entire curriculum for the trauma education course. Hopefully that should be done in the next couple of weeks, so we can get that pushed and move forward. Team Steps is an ideal communication platform in how we manage patients in trauma. It's not trauma specific, but what it does, it shows roles and identification of how people should move through the process. And of course, like I said before, developing medical simulation, that will be the key. I've checked at quite a few facilities in the area. There are really no medical simulation facilities around that are of significant impact. UC Davis has one, UCSF has one, Benninghoff has one. So I know part of Larry's and Kimberly's vision at some point in time is to develop a simulation program, which will be the key success, because outside of simulation for trauma, there's also simulation for stroke, simulation for MI management. So it's larger than just one service line. It's across the broad spectrum. Next slide. Part of trauma is community outreach. Our obligation and commitment to the community is to develop a Stop the Bleed program and a community-based hands-on CPR course. The other part of that is looking at the Falls program, which is not relegated to only to the skilled nursing facilities, but to the public and to the homes and just to the community at large, and the implementation of a variety of programs. That includes Tai Chi and other balance-oriented programs that's been shown to be beneficial to people in geriatric programs. What we also developed is a geriatric program for geriatric hip fractures. Part of that outreach is a part of that. Will be our first program that we're rolling out across the board. There is a high incidence of hip fractures within this region. So our goal is to optimize these patients prior to surgery, go through surgery, and hopefully have them back in a functional manner, at least into rehab within 72 hours. Part of that is pain management, which our anesthesia team and our emergency medicine team has developed a block protocol, which will actually improve outcomes, because pain management is one of the number one reasons that it's a showstopper for a lot of people and how they recover in the physical. Next slide. And as of today, we actually began to look at focus on our acute rehab program. So part of the ACS American College of Surgeons is that we have an inpatient rehab program to start with associations with outside facilities that we can move people to quickly, and again, get them back into a functional status, back into the community, back into their families. Next slide. Quickly, our timeline. We are up for our actual designation will be in May. That is through Alameda County. They will walk through and meet with the entire hospital, spend most of the time with myself and Dr. Morrison. That will be May. July, the expectation is we will open our doors as an official Level 2 trauma center. Within 12 to 15 months, we'll begin our journey into the ACS verification. That will be timed out in conjunction with Alameda County, because Alameda County is on a one-time schedule. So all facilities within Alameda County that are trauma centers will be verified. So they will verify Alameda County systematically first, then they will go to each individual facility and verify each individual facility. It's the easier process if it's done that way. So, and that's hopefully by 2027, and then we'll be ACS verified. And that's our final in-state goal, be ACS verified as a Level 2 facility. So, other projects, next slide. From that, we'll pull a lot of data and information that we can push out to the public so people can see. And again, will be safety measures, prevention measures, and where we're going, and we'll keep everyone updated to our progress. Questions?
Very impressive, Elwood.
Thanks.
I have a quick question. Thank you for the building that's taking place right now. It's exciting to see the preparation, the groundwork laid. My question is regarding volunteers. In your experience nationally and internationally, have you seen trauma centers utilizing volunteers, or are they more of a hindrance than a help?
I can tell you from University of Maryland Shock Trauma, we use volunteers.
Mm-hmm.
And a lot of times it was just escorting patients.
Okay.
I'm sorry, escorting families.
Mm-hmm.
And giving directions, and here's where this is, and here's what that is.
Mm-hmm.
Did we bring them into the bay? Not often,
Mm-hmm.
but they actually were more of patient relations
Mm-hmm.
in that perspective, and that's how we used them.
Okay.
So they were used.
I was glad to see that you talked about community education and bringing the community in the Heimlich maneuver, stop the bleed. Fall prevention is a big, big issue in our community, major issue as far as the elderly. Any thought as far as reaching out into the schools and incorporating some of this education into the health programs in the school so that the kids, as they go through junior high or high school, learn more about how to manage this, how to respond? I mean, we know from dealing with MIs and stroke that it's really important that the public be aware that you got to respond quickly and you give them the signs, the be fast type protocols for the stroke. So any thoughts on trauma? Has that been looked at in other areas?
So I can tell you, being in from Sonoma, I was covered Sonoma, also Santa Rosa for years.
Mm-hmm.
We did a couple different projects before, so Stop the Bleed will be one, along with CPR.
Mm-hmm.
In light of incidents around the U.S. in the past 5 to 10 years, Stop the Bleed will be beneficial in most schools.
Mm-hmm.
What we also did in connection with Youth Alive, so I'll connect with Youth Alive and we'll develop individual programs.
Mm-hmm.
But basic programs, texting and driving, first aid, and safety measures.
Mm-hmm.
We've done large productions for that over the years in the school system.
Mm-hmm.
So we did not to take up time, we did a production of an automobile crash, the impact of the family, the school, the students.
Mm-hmm.
We also did the first aid class to go along with it.
Good.
So it's something that can be done, and I highly encourage it.
Yeah.
So like I said, in working with Mike Jacobs from Alameda County.
Okay.
So part of that will be part of our Youth Alive process.
Good.
Talked about teaching to students because there's so many languages that are in this district that it's the kids that will be teaching their parents.
Yes.
And the kids will be the providers. They're going to grow up.
On the pediatrics, I think one of the education that you could do at school is also, explaining about concussions and things like that. Because I'm a pediatrician and I've seen many times, children who have fallen off on the bar. Mm-hmm. And when you really take an history, and I think it was probably a concussion, but they just got up and went off with a normal life. But, I think if that was educated to them, they might need an MRI or CT scan or whatever. So that is something that could be, if you're going to school and doing some education, I think that's something that could be stressed from.
And that's something, again, that's another component. So you get into sports, from the sports component, and we can target it from that direction, and look at sports and look at concussion protocols within the school system.
Mm-hmm.
So that should be first and foremost. Then also, just again, general conversation with parents, what to look for in the event. I fall off a lot of monkey bars. So what to look for when their child do fall from the monkey bars. And again, a lot of this data will be put into the system. So in about 12 months, we can work on the process now, but in 12 months, I can then pull back all the data and say, okay, out of, even though we're not the pediatric trauma center, majority of pediatric patients came in because they were falls. Like I can tell you right now, the number reason for transport for pediatric patients for Washington Hospital Center is by car. They're not coming by EMS. Most parents are going to grab their child, get into the car, and leave. So that's a little bit different. So the activation process will be different in trauma related to peds. So.
Well, thanks. I think it's a great contribution, starting from the whole package.
Thank you.
Starting from prevention to education.
Thank you. Thank you.
One of the things, I mean, you were saying that the incidence of fall after 60 is mostly in females. I was just thinking, if you look at life experience at birth, females definitely tend to outlive men. So I think the cohort of population after 60, there are more women than men, so that could be other.
No, and that's a portion of it, and it's just not here. It's universal. It's worldwide. Even in my data in the UAE, most falls were between 31 and 40, but they were work related.
Yeah, okay.
Most females at the age of 70 in the UAE had more falls, but they also were living longer.
Yeah.
So.
And Abu Dhabi, you must probably know, Cleveland Clinic has got a presence in Abu Dhabi.
Yes, so Cleveland Clinic, I was at Sheikh Shaboot Medical, which is split with Mayo.
Yeah.
Well, it was until about a day ago, but yeah.
We have a lot of expectations from you and your twin brother, Dr. Morrison. Good luck.
Thank you.
And welcome on board.
Thank you.
Especially good luck with the Oregon game.
Thank you, Ellen.
Thank you very much. All right, do you want me to? Yeah, so next we have Ed Bain, our Executive Vice President and Chief of Construction. He's going to do two presentations, but he's going to begin with an update on our bridge project.
Okay, can we bring these slides up? Okay, great. Can you guys hear me okay?
Yep. Yes.
Okay. So this is for the month of November. We're making good progress. We're still slated to be done here in the middle of January. And, you know, I feel better actually this month that budget-wise, we're in pretty good shape. So all pretty good news. Okay, so next slide, please. This is the beginning of several slides that show that we're getting the roof on. This is a material called dense deck that's put on before the waterproof membrane. Next slide. So there's the membrane going on. Next slide. There's roof, the insulation and the final membrane. Okay, next slide. That just gives you a different perspective on that. But again, the roofing going on. Next slide. Okay, so here you can see that we've got the waterproofing going on, and you can see a lot of the work underneath the bridge is complete. Next slide. Here you can see that we're starting to get the roofs put into place. I mean, excuse me, the windows put into place. And next slide. That's the framing, and now you see the windows put in. Next slide. Here's the exterior walls that are being framed around the main structure on the west end of the bridge. Next slide. Another view of the same thing, and we're getting the exit door out of the emergency stairs that is being framed in this shot. Next slide. This is showing you ductwork that is being extended off the HVAC system above the roof, and then the next slide will show you as it ties in down into the hallway of the bridge. Next slide, please. Okay, here you're starting to see the framing going in for drywall, so interior framing. They're framing around the window walls there, and you can see some insulation going in on the next slide. Okay. Next slide, please. Okay, you can see that not only do we have the plumbing in place, but now they're starting to put framing around the underside for the taking of the final there will be it'll be quote unquote the roof, or the underside of the bridge will also be the metal panels. Next slide, please. Again, another shot of the framing going in. Next slide, please. Okay, this shows you that we're completing all the waterproofing, and then we're getting ready to put the skin on, the final metal skin. Next slide. And here you're going to see some progress as they start applying this. Next slide, please. Getting more complete, and then final slide for this side. You can see almost a completed bridge look there. I have had one employee say to me, "It looks like it's always been there," which actually was the intention. Next slide. This is just the reverse side of the bridge, and there's the metal panels on there. This is facing the loading dock. Next slide. And that's showing as we're moving forward and getting close to completion. Next slide. There you go, final product. Okay, I think that's it in terms of the slides. Any questions?
On budget?
Yeah, so far we're still on budget. I've said it's going to be tight, and this month, it looks. I feel more confident this month than I did the last 2 months. So, yeah, we're still in good shape.
Thank you, Ed.
Thanks, Ed. It definitely looks like a bridge to somewhere than a bridge to nowhere. Thank you.
All right, the next presentation Ed is going to give on the facility master plan. I'm going to have Paul Kozerchenko, our general counsel for the healthcare system, do a short introduction because we have a corresponding resolution that goes with this presentation.
So, thank you, Kimberly. So, the resolution that you're going to have before you tonight will document for the record the master plan that is then going to be examined as part of the CEQA process. So we're basically planting a flag saying this is what's going to be examined, and then we've already engaged ESA consultants to help us do the environmental review. And basically what we're looking at are the changes from the 2010 plan to what is now being proposed. In generally speaking, the view is that the environmental impacts have lessened because the project is smaller in scope than it was before. But we still have to go through the process. And so tonight Ed is going to go over the plan. His presentation will be attached to the resolution. And so we have something that the consultants can use and the public can use to know what it is that you'll be looking at. You've seen bits and pieces of this before, but it's now in one place.
Okay, thanks, Paul. Yes, so as Paul has mentioned, this is something that we've had discussion with the board before, and it should be mostly familiar, but we have not had sort of a public discussion, and that's the intent here. So this presentation is sort of divided into the 3 steps of the master plan. This slide gives you the best shot of where we've come from. So we had the central plant, that was the first step, followed by CJR that was done completed almost at the same time as the central plant. And then we moved on to, starting actually at about the same time, Morris Hyman Critical Care Pavilion and the garage. We completed the garage in a year, and so that was functional while Morris Hyman was still being built. And that, of course, being completed in 2018. So we still have the additional building that's going in the back. If you look at the cross that's sitting there in the lawn, that's a location of the addition. And then we have the center, the entryway, which will be basically where if you look at the main canopy now and the main entryway, it will be parallel to that, pushed farther back onto the campus, closer to the entryway to Morris Hyman Critical Care Pavilion. Okay, next slide. I'm going to quickly go through these slides unless there's questions as we go through. So obviously, the purpose of the master plan is to give us the roadmap for the future construction. We want to make sure that we've got all the hospital services taken care of in all the buildings that, when we're complete, that everything is housed in appropriate seismically safe buildings. It is hopefully will allow operational efficiencies, and we're taking that into consideration in terms of the location of services and how we juxtapose them in the various buildings. We want to make sure that there's clear pathways and wayfinding through all the buildings, and that we're using basically we've got an optimal use of the resources, the capital resources that the district will end up owning at the end. Okay, next slide. Again, we've got this basically in 3 phases. So the first phase includes the patient bridge, which you see we are just about done with and will be done with in approximately a month's time. And then we have the Morris Hyman Critical Care Pavilion. Both of these projects and build-outs are funded by GEO bonds, which the voters voted on our behalf to go out to the market and get, and to support those. And so that's sort of our first phase or our first step. Next slide, please. The next is what we're calling our phase 3 building, which is the building that will be located directly behind Morris Hyman and will be, in terms of a footprint, pretty close to the total square footage of the footprint of the Morris Hyman Critical Care Pavilion. Next slide, please. And then the final phase, and I should say this, so the expansion building, I would be remiss if I didn't point out that that will also be paid for by the GEO bonds that have already been approved. The last slide will not be paid for by GEO bonds. We're going to have to develop this support for these internally, and it includes a lot of demolition work in the front of the hospital, and then final main entries and connection points for the CJR. That's the final or the third phase. So let's quickly go through all these in detail. Next slide, please. So as you're all aware, we have a lot of infrastructure that has been built for the Morris Hyman and the main building in terms of utilities and the central plant. This is our current layout of those utilities. And then in the basement of Morris Hyman, these are all the spaces that we did not improve, that we shelled in when we built the building. This is the amount on the basement, and then we also have another amount on the first floor. So the basement build out is going to look like this. Next slide, please. We have sterile processing, we have imaging, and we have pharmacy on the basement level. And then we have what's listed there as surgery support, is basically locker rooms and some storage. It's important when you look at this that the location of the surgery support and sterile processing is directly below the OR, and we've got 3 elevator systems in place, 2 to move sterile and dirty equipment up and down directly from the OR, and 1 is located next to the locker rooms, is going to be the transport for staff, surgeons, etc., to go up to the main OR after changing. Let's see. The imaging does include MRI, and we prepared for that when we finished Morris Hyman in terms of the ability to open up the side of the building to get it in there. There is still going to have to be structure done and the underpinning for the weight of the magnet. Next slide, please. Oh, this slide, I'm sorry, this is just showing you the circulation on the basement level, and it mirrors pretty much the circulation that that is currently there, even though these spaces are shell space. The only real additional circulation is going to be from the visitor elevators in the middle of the building over to the imaging area for outpatients that are going to be coming for various modalities, including MRI. Next slide, please. This is the shell space that's currently available on the first floor that will be built out for the OR. Next slide, please. And here is the OR layout. It includes 8 surgical suites. I believe it's 8 pre-op beds or holding area beds, and then 12 recovery room beds. Next slide, please. So you can see the circulation path here is on the main hospital part and on the existing Morris Hyman. It's very, very similar, but the things to note are, of course, we're showing circulation for patients for walk-ins to get to the surgery area. We're showing circulation for patients to come from ED to the OR. We're showing a circulation for patients that come from CJR to the OR, and we're showing some circulation of supplies that will have to come through that OR to get to CJR and vice versa, because that's our mode of transport. But those will mostly be surgical types of supplies, food and things like that we can access through other gateways through the existing building. Next slide, please. This just takes you through the rest of the building. I think the thing to note here is we had at one point talked about having a rehab unit on the 3rd floor. That's no longer a viable option, and there is a study going on now about fitting it into space, built-out space in the Morris Hyman Critical Care Pavilion. Next slide, please. Okay, so the first step in terms of the build out of the phase 3 building is going to be utilities. You can see there's an extended tunnel to bring the utilities from the central plant over to the phase 3 building. There's also utilities that are going to have to be worked on. They don't have to be done at exactly the same time as we're doing the phase 3, but these are in here that they're going to have to be done at a certain point because we'll need to separate off utilities from the existing acute care areas that will no longer take acute care after 2030. So it will happen around the timelines that we're bringing the other building online. It doesn't have to be as you may recall, we built the central plant to take some expansion. There is space there to take things like additional air conditioning units, chiller units, and such as that, some energy generation. But when we're all built out, it was built to support 1 million square feet. But in terms of your emergency generation, emergency water, things like that, you're not going to want to have the subacute or outpatient areas on those same sort of utilities. Next slide, please. So this shows you first the build out of the first floor. And I think the key things here are not so much how much space each of these departments has, but we're fitting in basically everything that's left in the 6th floor or 6-story main building and getting them into this building. So you can see a dining, kitchen, rehab, endo, cath lab, lab, and such as that slated to go in here. You also have here, I think one of the features here is access to the birthing center will be off the back parking lot of the campus now. And we have the ability to do a couple things, do designated parking there, have it a little bit more patient-friendly for OB patients and have them get direct access to the floor without going through a lot of public spaces. So that provides a little bit more of a concierge service in terms of parking and access to the facilities. In terms of the rest of the circulation, pretty much the same. You see that you access the new building via Morris Hyman, and we have some, natural connection points for public and then for support services. Next slide, please. This just shows that as you go up in the building, there are going to be a couple of floors of 50-bed nursing units to replace what we have. Sorry. Next slide, please. Next slide, please. Oh, and the other thing is just to note the simplicity of the circulation, both for visitors coming into the units and then for the service side of the house as well. Separate elevators, separate hallways for service. So you've got two floors that are basically mirror images of each other. Next slide, please. And here on the top floor, you have sort of a self-sustained OB area. So people can get in from the back parking areas, back entryway, catch the elevators, go up to the third floor, and get into a self-contained unit that has the LDRP, the NICU, the C-section rooms, the well baby nursery, all in one place. And I think the other thing that we have discussed that isn't shown here is the advisability, perhaps, of putting another patient care floor on this roof section on the east side of the building. Next slide, please. So here we have sort of the phase 3 or the last stage of both demolition and fairly minor construction. So this is the ground or basement level. What's to note here is in the phase 3 building, you've got storage there, and that's mainly what we see that, we're going to have taken all the storage that we have left in the acute care buildings, and so we can utilize some space in the basement for storage. Also, we think it's important that there's a connection so that people can access from the patient care floors things like imaging, ultrasound, and any other services that may be on the any other perhaps outpatient services like a rehab or something like that from the acute care side. The other thing to note is that this is basement level, and if you note in the middle of this drawing or of this plan, you've got a purple circulation path that takes a perpendicular cut up towards the CJR. That would be new construction. The main section of that connection is an existing connection on the basement floor that's behind the loading dock. And then we would have a branch off of that to some elevators that would be tied into the bridge. And we've built the bridge to make this connection and have it structurally ready to make this connection so that things like food, supplies, etc., can be taken off of the first floor and everything to get to the CJR through the seismically safe or seismically upgraded pathway. I think we've talked about this in the past. Once we hit 2030 and we have a compliant building, all services to those buildings have to come from compliant buildings. So we will no longer be able to access CJR through the non-compliant 6-story building and associated hallways, etc. Next slide, please. This then gives you an idea of what our ideas are for access to the hospital buildings while we're doing this demolition in the front. We would be building a protected walkway from the sidewalk on Civic Center Drive so that the main parking would now be over at 2500 and people will access this building coming across the street and getting into Morris Hyman and the phase 3 building in that direction. And And there will also be access to the CJR and the rest of the outpatient buildings while this demolition is going on from the doctor's entry. Okay. Next slide, please. So this gives you an idea of circulation through the whole campus when we get to the end. You can see we have enhanced parking in the front of the structure. We have a larger roundabout for drop off to the main entryway. We have a new light at Maury Avenue where the entry is into the hospital. We have the current ER circulation plus ER parking. We have the circulation back for OB that comes off of Bartway, and we have the circulation for the employees to come to the parking and then enter the building via pathways that are really already established. So what we do on Bartway still needs to be determined. What kind of access are we going to allow? Are we going to make it a private pass-only type thing for OB patients? That really is the thinking right now versus utilize it for staff to go in and out as well. Let's see. Anything else on this? No, that does it. Next slide, please. So here you get the idea. When we're done, you've got a drop-off point in the front of the hospital. There's a new main lobby coming in. There's an admitting space right in front of you, and then access to all the buildings, whether you go left or right, left to go to CJR, right to go to the other two acute care buildings. And so that's the master plan in short. And just if you could put the next slide up. The EIR was developed with this, you may recall this plan or this drawing. This was what was envisioned for the future and what we had in mind when we did the original EIR. You can see a couple of things. Number one, the patient tower behind Morris Hyman was envisioned as something that would be 6 or 7 stories tall. So that's now been cut down to 4 stories. So the square footage of that, or that in the intensity of what's going on to the lot is reduced, which should be, which should make this EIR basically just an update on what our plans were. We've also done away with the triangular building that was slated for the front, and we're keeping, some of the 1956 building and some of the other buildings that were built and are compliant but weren't on this plan, such as the loading docks that have been constructed over the last few years. So we're not loading the campus to the extent that we were in the original plan. To indicate that in terms of what will be happening with the next EIR. And with that, I think I'm done, and I'll take any questions.
Well baby nursery on the 4th floor? A well baby nursery? We're really gonna have a well baby nursery? We haven't had one for.
Well, I think we've had a few bassinets that if we needed to put any babies that are not with their mom, I think I believe we have the ability to do that up with, but we haven't. So, and a lot of this is just, this was what was done a while ago, and so now actually we're sitting down and, because, we've talked about a level 3 nursery. We've talked, all of those kind of things. So a lot of this was just sort of making sure that there was space for everything. And some of it could be mandated by the state as to having certain things too. I don't know. So we're actually going to be working with Radcliffe. We're going to be Ed's going to work with us to kick that off just in the next week in terms of starting the process of looking at this and what is it, and really now saying, okay, how many beds do we need here? What do we need there? Those types of things. So,
yes, the infill projects are in Oshpod. We anticipate the first set of comments coming back in January. We don't anticipate having to go ahead until the summer of this coming year for the infill portion of what you just saw. And Kimberly's right, and when we lay out something like the birthing center or that whole area, there's codes that require certain things to be there. Like it might be surprising, but we have well baby nurseries in our existing facility. We just don't use. So there are codes of what you have to build out.
So, would you like to take the action item for the resolution out of order and do that one since we just had the resolution?
Are you ready for that, Mr. President?
Yep.
Okay, that would be action item A. Mr. President, I move for adoption of resolution number 1259 that the Board of Directors authorize and direct the Chief Executive Officer to proceed with the review of the updated master plan pursuant to the California Environmental Quality Act. Second.
Director Stewart,
Aye.
Director Nicholson,
Aye.
Director Wallace,
Aye.
Director Yee,
Aye.
Director Eapen.
Aye.
Thank you. Thank you, Ed.
Thanks. So, give me the report, Mark, Sally, to the medical staff report. Mark, are you there?
Yes,
There he is.
sorry, just had to unmute myself. Hi, everybody. Good evening.
Good evening.
A lot of good reports that are going to be hard to follow here. Mine is going to be shorter and less exciting. The medical staff census, we have a grand total of 619 medical staff, of which 342 are active. The rest are a mix of various categories, including administrative, ambulatory, consulting, courtesy, or on leave of absence. You may have noticed in the medical staff lounge, we have now on the screen projecting the new medical staff members with larger pictures for so people could recognize them. I worked with an anesthesiologist, one of the new ones today, who was in the lounge getting coffee, and she's like, "Hey, that's me up there. What's my picture doing up there?" And I had to explain why we were doing that, but it was a surprise to her. We had a holiday luncheon for the medical staff on December 1st, last Friday, that was well received. Want to let you know a couple of announcements. Dr. Akioli is retiring. She'll be retiring, I believe, January 8th officially. And Dr. Azizarad and Dr. Sharia will be the incoming co-medical directors of the critical care and IMC departments in her place. The aquablation program is going well. I did my 16th case today, and several of the other urologists are doing several cases. So I believe we're on track to do somewhere in the range of 30 to 35 cases within the first 2.5, 3 months of this program. And we're getting more efficient with it. The medical or the OR staff are getting more comfortable doing it, and we're having really good outcomes. And I will be giving you a more detailed report later as we gather more data. I'll have a presentation for the board. And the final thing I wanted to mention, Dr. Andrew Vargas, I ran into him today as well, and he and his colleague have opened up a pain clinic in the building at the 39141 Civic Center building where my office is downstairs. And they are hoping for more referrals, and this is a service that we really needed, and I look forward to having them get busy and referring more patients to them. And that is my report, if anybody has any questions.
Thanks, Mark.
Thank you.
So now we'll move on to the service league report. Sheila Vijay.
Thank you, Dr. Eapen. Good evening, district board members. On behalf of our volunteers, I again extend a warm welcome to all of you, and I wish you happy holidays in advance from all of us in the Service League. In November, we had 172 volunteers who worked together, dedicating a total of 1,841 hours, staying true to our ongoing commitment. I'm extremely happy to announce the resounding success of our recent masquerade sale on November 27th, 28th, and 29th. The commission generated by the sale for the Service League was $10,500. This was an increase of almost $5,000 from last year's sale. The kickoff of the gift shop holiday season was a tremendous hit as well, drawing people eager to purchase items. From the holiday show, the gift shop generated $1,800 in merchandise sales and raffle tickets. This month, I want to highlight our latest volunteer initiative, the No One Dies Alone program. The No One Dies Alone program, in short, NODA program, originated at Sacred Heart Medical Center in Eugene, Oregon in 2001. Established by nurse Sandra Clark, it ensures that terminally ill patients don't face death alone. The concept quickly gained recognition and has been globally adopted by numerous healthcare facilities. The NODA program was initiated about 5 months ago at Washington Hospital and is managed by Spiritual Care and staffed by Service League volunteers. The program highlights a great collaboration between Spiritual Care and the Service League, and I want to express my sincere thanks to our Spiritual Care Coordinator, JB Goodyear. Thank you, JB. This program provides crucial support to nurses and offers solace to individuals in their final stages of life. Volunteers are also able to offer respite to family members sitting vigil with their loved ones. To become a NODA volunteer, individuals go through an interview process followed by comprehensive training sessions that equip them for their responsibilities. Before officially commencing vigils, volunteers undergo shadowing experiences, providing insights into the dynamics of end-of-life care. During vigils, volunteers offer a compassionate presence, addressing the emotional and physical needs of the patient and their loved ones. In my personal experience, I had the privilege of vigiling an elderly patient through NODA. The patient's daughter, who was overwhelmed and was extremely stressed, she was also an out-of-towner, so that added more stress on her. She expressed deep gratitude for the relief that I provided. It was a very moving encounter that highlighted the program's impact on families. Having participated myself in more than half a dozen vigils, I can attest that the No One Dies Alone program is not just a commitment, it's a deeply moving experience, highlighting the profound significance of human connection in life's most poignant moment. Our NODA program currently has about 10 volunteers who stand as a testament to the values of compassion, empathy, and community that defines our mission. That's the end of my presentation. Please let me know if you have any questions.
Thank you so much, Sheila.
Thank you, Dr. Ethan.
Wishing all you and all the team a great holiday season.
Thank you very much. Thank you to everyone.
And I just happened to read the bumper sticker in front of my car today. It said, "Volunteers go to heaven."
You just made my day, Dr. Epen. So I definitely know where I'm going at the end of my life. And and just when I presented the NODA program, thank you, Dr. Epen.
I do want to just say something about the program. That was something that JB, and just during the pandemic, I think that there were many struggles with given the circumstances that many of the staff and the physicians faced and JB did during that time. And it was a commitment. He and I talked a lot about the feeling of really trying to have nobody ever have to die alone. And so that was something he spent a lot of time looking at different programs and what others were doing. So I very much appreciate the volunteers and Sheila, you being part of it. And I do think it is truly making a difference for our patients and family members.
Thank you, Kimberly.
Right.
All right, can I introduce our next speaker? All right, our next speaker is Jeff Van Dorn, and this is the Lean Report. and he's the Director of Marketing and Patient Experience for the Washington Township Medical Foundation. Jeff received a Bachelor of Science degree in Exercise Physiology from California State University, Chico, and a Master of Science in Healthcare Administration degree from California State University, East Bay. Prior to his role at Washington Township Medical Foundation, Jeff joined Washington Hospital Healthcare System as a rehabilitation aide in 2016. In 2019, he transitioned to the Community Relations Department as a Community Relations Specialist. Shortly after his time with Community Relations, Jeff became a fundamental part of the Washington Township Medical Foundation as the Manager of Marketing in 2019. He was appointed Senior Manager of Marketing and Process Improvement in 2021. Jeff has recently been appointed the Director of Patient and Marketing, Patient Experience and Marketing for the Medical Foundation. All right, Jeff, I think you're going to be talking about improving the patient experience.
Thank you, Kimberly. Can everybody hear me okay?
Yes.
Excellent. I'm going to share my screen. Again, thank you, Kimberly, for the kind introduction, and I'm really pleased to be presenting and given the opportunity to present about patient experience in Washington Township Medical Foundation. So some of the key lean principles that we focus on in the Medical Foundation and also within the healthcare system, you see in front of you here. So understanding our patient's perspective, data-driven improvements, engaging staff and providers, and transparency and accountability. Now, WITMIF has been a successful adopter of the Washington Daily Management System. It has been integral to our success with patient experience initiatives and has helped the staff understand the importance of patient experience to the organization, allowing for effective problem solving to address challenges in the clinic. Here you see two of our most common examples of visual management tools. On the left, our process owner board, which defines our strategic priorities, and it's intended for management and senior leadership. And then on the right is the frontline board. This is for daily operation, what needs to happen today for our patients, and it's intended for staff and management. So here you see our patient experience organizational priority. This is an organizational priority for the hospital as well as the Medical Foundation. What's particular about the Medical Foundation is we took a look at our structure and we developed a new structure for our unit goal, which is seen on the process owner board. We've changed this from fiscal year 23 to fiscal year 24 to really refine what the clinics are focusing on. So the new strategy is to take 3 of the Press Ganey, which is our survey utility, specific categories that the operations managers and the assistant clinic operations managers see when they're seeing their reports. Those 3 are moving through the visit, access, and how well staff work together. You can see for our women's health, we are focusing on increasing moving through the visit. So that is a relation to delays and wait times. We're trying to increase our fiscal year end 23 score of 85.96 to 88.57 by fiscal year end 24. Now, every clinic has its challenges. You'll see some of ours there: provider schedule changes, access issues, and staff turnover. But the department has been really great at performing some of these patient experience initiatives, and I'll go through a few of them with you with a focus on the 2 at the bottom, which I'll get to. So schedule templating. So looking at the needs for patients for improving patient flow, looking at our same-day appointments, whether that's reducing blocks or creating new visit types. What was really special is we had Laura Anning, our Chief of Patient Experience with the healthcare system, come to our site at Women's Health and a few of our other pilot sites in the Medical Foundation and conduct care communication training. That's where she educated our staff, our providers, as well as the management team on heart training, as well as other care communication tactics. We also really developed our transition from clinic to hospital for patients, so that process flow. So that was seen by doing direct scheduling into many of our clinics, as well as to some of the interdisciplinary clinics within the healthcare system, and collaborating with maternal child health. Now, I was mentioning that we're going to be talking about the 2 areas here, which is wait time management and leader development. So our project that we were working on is improving communication and wait times. You see here the challenges. We didn't know who was waiting or how long, and we weren't standard with our communication. So what did we do? We set up these wonderful timers that you can see on the screen here. Very simple in design. It would ring after 10 minutes. After that ring, our staff would go into the exam room and then inform them on the patient on the provider status and let them know how much is the expected wait time, and deliver any opportunity for service recovery at that time. So when going through this project, we had some key learnings. Patients were being informed of the wait, but we didn't address why patients were waiting. And we'll get into that a little bit. So again, we didn't know the why. So we updated our project and looked at our second reason, which is reasons for waiting. So we started to utilize trackers to really define this. And you can see here on your bottom right chart is we looked at delays by provider as our first tracker. So you can see delays greater than 10 minutes. So this is how many times our timer was beeping. So you see on your x-axis there, provider 1 had 10 single rings at 10 minutes, and provider 5 had quite a few single rings at 10 minutes, a few at 2 rings, and 3+ rings. Now, again, this chart is just to visualize one that we identified an issue with providers, but that didn't really tell us the whole story. There was more to it, and it was affecting the subsequent patients. If you had a delay early on in the day as a provider, it would roll and cascade into more delays as the day went on. And we really had to look at all the visit types. Here you can see a lovely Pareto chart. What we're seeing here is all of our reasons for delay on our x-axis: appointment ran long, patient late, paperwork, double book, surgical delay, resource issues. And there are multiple factors, as we have learned. When we look at this, we see that a few of these items on our left side are really the responsible parties for the delays that we were seeing in women's health during July 10th to August 4th. And that affected, and they can make the largest contributing factor for improvement work. So our women's health team really started to focus in those key areas. And I'll get into a little bit of that in the future. So we looked at our daily management system, the things that we introduced earlier, and we looked at our process owner board. So it allowed visibility around our goals, and it kept management accountable. We kept looking at that moving through the visit score. How are we doing on this month? How are we doing weekly? And to follow that unit goal as we progress through this project. And as leaders, our leaders would round and make sure that our management team was, one, meeting their goal and then removing any barriers that came up so that we can make sure that we met that unit goal. Now, our frontline board, this was very important for the improvement work that we saw in women's health. We were able to bring those trackers that we just showed in a few slides ago that back to the frontline board and really demonstrate to the staff what are the big issues here in women's health and really process through that with the team. We know that the team that is in the front lines is the ones that's doing the work, and they're going to be able to see the improvement first. A great finding that also came out of this is it got the providers really engaged. They started competing to have the least amount of timers go off. So there was a sort of healthy competition that naturally came out of this project. Another element that I want to discuss is the leader development, and this is the development of the assistant clinic operations managers. Now, they play an important role in WITMIF improvement efforts, but through mentoring, through the operations managers and also the leadership team, they were able to perform many of the functions that you see here. Sorry, I just heard some feedback. They're able to perform many of the functions seen here. So running the frontline huddles, coaching their clinic leads, looking into the data on a weekly basis, calling patient comments, whether they're negative or positive, trying to get that feedback back to us, and to really utilize service recovery when we're dealing with our patients, and working with the Lean Office to develop some of these beautiful trackers. Now, you'll see here is the effect of the daily management system and our leader development, which is the improvement. So this is the moving through the visit score, what we've been tracking on our process owner board and our unit goal. You can see the target line is our yellow bar going across the middle. That's that 88.54, which we've been trying to hit for fiscal year at 24. You'll see the various trend lines. Now, there's a lot of bar graphs here, but the blues are the total of the moving through the visit score. Okay, and the orange is our information about delays, which is one question element of the moving through the visit. And then the gray bar is our wait time. So the orange bar and the wait bar combined equal our blue bar, which is what we're trying to improve. You'll see that we've gotten 3 months of over goal, which is very impressive for this practice. And with some sneak peeks that I've looked at in November, we are also looking to be above our goal. We have a moving through the visit score of 88.62. Now, we talked about our unit goal and how we restructured that. That doesn't mean we lose sight of the bigger goal with patient experience and our likelihood to recommend score. So hopefully you all have heard of this. This is our primary metric that we look at on the medical foundation side as well as the healthcare system side. Now you see here, we looked at the same period, and we see that also that improvement that we've seen across, May to October. Now, I do have some preliminary data for November, and we're showing that we're at a 94.4, and it's again right under our goal line for likelihood to recommend, but it's showing that improvement effort that we've seen with focusing in that moving through the visit area. All right, and just really quickly, I want to go through the key takeaways here. So what we learned through this project is consistent communication and visual displays really lead to accountability. That's for the staff, the managers, as well as the providers. Again, engaging all of the players, all the stakeholders in this process really showed that improvement over time. Looking at the root causes, not just settling on your first tracker and actually going through, and they developed 10 to 12 different trackers just to really define what that root cause is, and leveraging the lean tools to help visualize the data and help bring it back to the people that are doing the work. Now, I just want to talk a little bit about the improvements that have been coming out of this. So since this project has taken place, we've updated our scheduling templates for all the providers. We refined our scheduling process and educated the frontline staff in that area. And our future and ongoing projects right now are developing a pre-appointment questionnaire and to get that online so we save those patients time. And that really is going to improve that, not only the moving through the visit, but also their overall satisfaction. I'm going to open it up at this time for any questions.
It's great work. It's hard work, challenging, a lot of moving pieces. So keep at it. It's really important that we get it right. So thank you for working on this, Jeff.
Yeah, thank you, Dr. Nicholson.
Yeah. Thank you so much. One of the things I have found is, I think more than 50% of the patients that the small sample size you showed, the reason for is patient running late. So there are a lot of things that are within our control, but patient running late, I don't know what we can do with that. And now, with the questionnaire being sent to them, I'm sure one of the greatest excuses they would give is, before I got out, I was waiting and filling up all these forms. So that's why I got late. So
it is sort of a double-edged sword, and that's why we try and look at all the reasons and try and attack the ones that we can make the biggest improvement on.
And in my experience, moving the needle on this press-gating score, once it is above 85, the needle moves very, very slowly. It's not easy. And if you can do almost 3 point, those things, God bless you. I'm sure you can do it.
Thank you so much. And it's really a dedication to the team and the operation and all of us working seamlessly together.
Thank you.
Okay. Well, thank you, everyone.
Thank you.
Thank you.
So yes, tonight we have a quality report, and it's the annual critical care program update, and it's by Dr. Carmen Akawili. So I'd just like to take a moment to introduce her. She is, and I know many of us know her well. She's been practicing pulmonary and critical care and internal medicine in Fremont since 1991. In 2008, she became the director of the intensivist program for critical care. Dr. Akawili is board certified in internal medicine and critical care. She's also a fellow of the American College of Chest Physicians and a member of the Society of Critical Care. Currently, she is the medical director of the critical care and intermediate care units and is the interim medical director of the palliative care program at Washington Hospital, which began in 2016. I also just want to say, I know Dr. Mark Saleh mentioned, this is the last presentation in this role that Dr. Carmen Akawili will be presenting. She is retiring in January 8th, and so I just want to take a moment to really express my deepest appreciation and gratitude for all that Dr. Akawili has done for the healthcare system and for our patients. She is an amazing and integral part of the care team in the critical care units and in INC, and she truly has given countless hours to our patients and to this healthcare system. And I just know that she truly lives the patient first ethic, and she will be missed very much by all of us. So thank you, Dr. Akawili. I've worked with you for a long time.
Thank you very much, Kimberly. That was really kind words. Anyway, yeah, so I'm gonna try to go as fast as I can with my report. It's been a long day for all of you, and I hope you don't sleep for the meantime. Okay, my slides. Do you have my slides, Shirley?
They're going to pull them up. Just hold on,
Okay.
Dr.
But anyway, it's been 32 years and 15 years in critical care. I'm just going to start so you know. So the first ICU was born in Copenhagen in 1953. So go ahead, the next slide. And we had our critical care unit at Washington Hospital in 1963. So that's 10 years later. So 45 years later, we established the intensivist program at Washington Hospital. That's in 2008. It was still an open ICU. Any doctor can admit a patient in ICU, and any doctor can admit and discharge patient in ICU. So eight years later, in 2016, the board approved the intensivist-led critical care model, in which all patients in the ICU is admitted by an intensivist. Then we went to Morris Hyman Pavilion 2018. And next slide. So the model has been the same since then, 2 intensivists per shift. We're now 24, 8 full-time, and we're all 100% critical care board certified, and we're double boarded. Some of us are pulmonary critical care, emergency room critical care, internal medicine or anesthesia critical care, and pretty soon Dr. Morrison will be surgical critical care. Next slide. So the same program goes before, to provide the highest quality evidence-based patient-centered care and to engage patients and families in comprehensive, highly coordinated care with a human touch. We want to identify and improve condition of the critically ill patients. We want to provide appropriate, reliable, and timely care, integrate and engage patients in family care, and create an effective interprofessional care led by intensivists. Next slide. So for critical care admission, as you see in the last 4 years, there's steady admissions. It plateaued since 2020 to 23. This is because of effective triaging and appropriate admissions by the intensivists. Next slide. So what we do is to assess and know the gap of our ICU, we have what we call the ICU index. It is divided into physician management, evaluation, multi-professional teamness, and quality process. Next slide. And you will see in 2008, our quality improvement is good at 80%, and safety, not so much on family care, protocols, RT staffing, where we have good pharmacy and RN staffing, not very good with effective teamwork or multi-professional rounds, and of course, physician management. So now, in 2023, next slide, you'll see that everything has improved, especially the teamwork, effective teamwork, multi-professional team rounds, and of course, because the intensivists are running the show and coordinating the care, this has improved in terms of the IC index. And all to the quality improvement, family care has improved by 80%, safety is still there, technology is improved because of EPIC, in 2014, protocols also has improved and has reached the level for the Joint Commission. And in terms of leapfrog, we're okay with intensivist training and coverage. So next slide. So we continue our evidence-based practice from COVID management to now surgical critical care, focusing on cardiothoracic surgery, trauma, and neurosurgical intervention. Next slide. Let me know if it's too fast. So this is my timeline or fishwork for quality initiative over the last 15 years since we started the intensivist program. So in 2008, we started education, education, education. We have the multidisciplinary grand rounds. This is including not just the doctors, but all the rest of the healthcare professionals, nurses, rehab people are all invited to multidisciplinary grand rounds, and we invited thought leaders or experts in the field doing this. And we've done this now every year since 2008. We were part of the Surviving Sepsis campaign, the Fundamentals in Critical Care course, where we trained non-intensivist professional or specialists. We were also did the Delirium Initiative, and then the family care, having these diaries initiated. Finally, in 2014, we created the ICU clinical operations, where we have the different specialties or different units, rehab, pharmacy. Everybody is in that committee to know the day-to-day functioning of the ICU. And then, as I said, in 2016, the board approved the intensivist-led ICU. Another thing is 2017, we hosted the Society of Critical Care Liberation collaboration at Washington Hospital. Then we moved to Morris Hyman Pavilion, earthquake-free, private rooms to prepare us for COVID. COVID, it was really good that we have private rooms, and infection control was better. And then we continued all these initiatives, and now we're participating in the LeapFrog survey in 2023. Next slide. So we started with paper checklists inspired by Atul Gawande. In 2008, we were writing everything, making sure that everything is done from why the patient is in ICU to have you updated the family, and this is done per shift. Next slide. Okay, this is what we did. We created our brochure to know for the patients and family to know who we are. And then we have the diary on the right side and getting to know you questionnaire. We also prepared a guide for families for meeting. This is well all recommended, and we did this from 2008 to 2014, and now we're just continuing and trying to maintain it and sustain. Next slide, please. So in the sepsis initiative, the nurses had a grant from Gordon and Betty Moore Foundation to decrease sepsis hospital-wide. They collaborated with critical care and emergency room, emergency medicine, and we published in Critical Care Journal on the impact of community-based education on sepsis. We were the first one that submitted this abstract to discuss or educate the community. So they like the publication. They like the article. Next slide. So this is what I said. The fundamentals in critical care is to train our non-intensivist colleagues, surgeons, neurosurgeons, neurologists, internists. You can see Dr. Smith there helping us with airway management, Dr. Achanta there looking at ultrasound course, and Dr. Nicholson also is helping us lecture on cardiology, and the simulation lab where we did some CPR and ACLS. So this went on for a couple of years, around 5 years, I think. And I think they like it. Next slide. So the delirium initiative was good because, as you know, delirium can increase length of stay, morbidity, and mortality. It can also increase long-term harm to the patient, and of course, increase costs. So the Washington Hospital is an early adopter and a leading center for delirium management. And it was implemented only by a few academic centers and even fewer community hospitals at that time in 2010. So we were one of the lead people. Next slide. And then we formally joined the Society of Critical Care A to F bundle, which included delirium letter D and all the rest with early mobility and family engagement. Next slide, please. In 2017, we hosted the West Coast ICU collaborative meeting at Washington Hospital. Some of the Bay Area facilities were Sutter, UCSF, and VA Palo Alto. Next slide. At that time, we standardized frequent pain management and improved family engagement. And over the 18 months, we were able to have greater percent receiving early mobility. We decreased the average length of stay by half a day. And we were able to decrease the median hours on mechanical vent by 20 hours per quarter. And they published this 18-month study, and Washington Hospital is highlighted on the Critical Care Journal. Next slide. And at that time, we were recognized as the top performer for the A2F compliance, Washington Hospital. Next slide. So this is our delirium prevalence from 2008 to 2023. There's a decrease of halfway from 40% to 17% in 2023. The national average is around 30%. So that is quite an accomplishment, and we have maintained more or less between 17 to 20%, lower than the national benchmark. Next slide. Also, we were recognized to be a top team performance for the early mobility because we started it early and we are continuing it right now. This is a patient from 2021, mechanically ventilated, awake alert, and on his second day was now able to get out of bed and walk around. They just don't lie around in our ICU. They need to get moving. This is in collaboration with RT and nurses and the rehab people. Next slide. So for our ventilator, also we'll see a decrease in the duration of mechanical vents from 2008 to 2023 by half a day. So most of our patients stay mechanically intubated for around 1.7 days. Of course, there are outliers, but most of them less than 2 days, as opposed to the national benchmark of 5 days. We also have the reintubation rate on the left lower graph, also less than 10% of the national benchmark, and the self-extubation. We also look at all these things. We do a root cause analysis as to the cause of this. Most of these are positive delirium and psych patients, agitated patients. Next slide, please. So our top discharge diagnosis has always been sepsis. In 2023, sepsis and cardiac cases second, and neuro cases is increasing. COVID diagnosis 19 is no longer among our top diagnoses in 2023, and it was in 2021, as you can see in the lower pole. Next slide. Our critical care mortality is within the range of 10 to 29. The 17.8 in May, when we drilled down, was mostly due to brain hemorrhages. So neuro cases was the cause of the increase in the mortality, but more or less all the rest are just the same. Our highest overall mortality is due to sepsis, septic shock overall. Next slide, please. So we have a decrease in the average length of stay over the course of the year, meeting the internal benchmark, which is 4.9. And this is the result of improved hospital-wide patient flow and our multidisciplinary rounds with the case management. It is below the benchmark of the internal benchmark is 4.9, and the SCCM benchmark is 3.8. So we're under the benchmark. Next slide. Also, for readmission within 48 hours, we have lower readmission compared to our internal goal of 4%. Most of these readmissions, we also take a look at them, and there's mostly non-preventable. So a patient that was discharged would have a separate kind of problem, like another heart attack, but not something that we can prevent. Next slide, please. So for infection prevention, we are happy to announce that we did not have any Club C incidents in 2023, and a little bit lower than expected in C. diff. Our challenge is CAUTI, or the catheter-associated UTI. There was increase in 2021, but the trend is going down, but it's still not at at goal, which is as SIR or standard infection rate of 1. So our action plan was empowering the physicians on minimal use of Foley catheter, particularly after 2 days, encourage early removal of Foleys. We've spoke with Dr. Saleh and other urologists on how they can also help us, give them some medication to improve BPH or the benign prostatic hypertrophy so that the Foleys can be removed. Nursing leadership make rounds twice a day. And then we also did education and training and supervision for nurses. This is something that we're gonna have to follow up daily and yearly. Next slide. The other challenge we have is the ventilator-associated events, which you see increase over the COVID-19 pandemic. But after the pandemic or when COVID cases has decreased, you can see decrease also in incidence of VAE. However, we have not been below the SIR, which is 1. So we're still watching this very closely. And we do have an action plan. At one point in time, we have the VAE task force reviewing it more routinely, but now we are doing it as a committee, ICU leadership committee in the ICU. Next slide. So COVID in ICU. Since you know that COVID cases has increased again lately, but this is the gray bar is the hospital-wide COVID positive admissions. There's an increase in 2022 and then went down to 435 in 2023. But if you look at the ICU, which is in blue, there's a continuous decline in the admissions of COVID positive in the ICU, meaning to say there are less serious patients. They don't have to come to ICU. Next slide. So for the all hospital mortality, there's also a decrease from 2020 to 2023 from 11 to 5%. Our ICU mortality also has decreased 37, 39 to about 20, 21%. Most of these patients are vented. And so around 28% are vented. The thing that's positive is that our ICU length of stay also has decreased from 8, 10 to 5.2 days. Next slide. So education has been our initiative, and this is the one that attracted all the other team members or different. So for May of 2023, we always celebrate critical care awareness and annual recognition of our team. I want to point your attention to the May 17 Future of Critical Care with the Use of Artificial Intelligence. We got Dr. Michelle Gong from New York. She is an expert on this. She's a critical care director, but she is telling us that artificial intelligence should not dictate what we do, but we should be involved now early so that we can dictate what will be in the artificial intelligence. So whatever it's worth, I am encouraging all my critical care colleagues to know more about artificial intelligence in medical practice or in critical care. Of course, we wanted to know more about care beyond cure among cancer patients. So Dr. Krishna Suri did the palliative care. And of course, we want to know more about what's next with COVID. Next slide. So aside from that, we created, or with the encouragement of administration, we had the quarterly critical care case studies started in 2022. Important cases in ICU is being discussed. We also helped with nurses, giving them interprofessional education lectures during their nursing skills, ultrasound course for emergency room physician, and then community lectures, especially in sepsis. And recently, we participated in the trauma conference at Stanford. That's the picture, multidisciplinary team attended in August of this year. Next slide, please. So our next step, we want to continue to improve our communication strategies by partnering and collaborating with palliative care and spiritual care for better patient and family experience. We update them daily but we still need to do routine family conferences. Of course, I already said earlier, we want to expand and explore the use of artificial intelligence in critical care to improve the quality and safety of our patient. And of course, again, strengthen and education and patient experience in the surgical critical care, particularly in trauma and neurosurgical intervention. And that's it. That's my last ICU report to the board. Thank you all very much for supporting the intensivist ICU program. I hope you understand. I went so fast.
We understand very well, Carmen. We really do. And I want to thank you personally, from my heart, for your great work over the last 30 years, but most importantly, over the last 15 years, where you have had just exceptional skill in team building effective teams that work together, focused on the patient to bring the best of care to the bedside, and that excellent care to our patients of this community. So you've really embodied what we're all about as far as the culture of this institution. And the proof of that, I think, is shown in the statistics that you presented, which are pretty profound. They speak a lot. I personally appreciate that. It's just been a delight to work with you over all these years. We won't say how long, but it's been a real delight. And I know you've worked a lot with Omida Zizarad and Cyrus Shariat, and I hope they're able to equal what you've been able to do.
I think they will. And I told them, you know, like what my dad said, if you do it for the good of the patient, you'll never go wrong. So that's what we should all remember. Thank you, board, the board and administration. Thank you for supporting this program. It really went well because of your support. Because I spoke with Palo Alto and the other leaders. Administration and the board has not really supported all their programs. So I'm very lucky. I was in the right place at the right time. Thank you very much. I'm happy to say that.
Thank you. Thank you so much. Thank you so much, Carmen, for all your services. I'm sure the community really appreciate it, and they would definitely miss it. And in my own words, in our common language, let me tell you, maraming salamat po. Thank you.
Okay. Thank you. Bye.
Yeah, so next is the finance report. Tom McKenna is going to start with October.
Okay. Can you hear me okay?
Yes, we can, and they're just bringing up your slides right now.
All right.
All right. Can you see them
Okay,
too, Tom?
let's move to slide 2. Thank you. October 23 continued what we saw in prior months. And what I mean by that is lighter volume. Our case mix was a little bit light, and our payer mix is continuing to change more towards governmental. The following are a few handful of key observations for this slide. Inpatient average daily census of 145.8 was below the budget of 164.5 by 6% and by 8.6 on a year-to-date basis. Combined average daily census was unfavorable to budget by 16.4 for the month of October and 5.1 year-to-date. Discharges were unfavorable to budget by 114 for the month of October and unfavorable by 265 days year-to-date. Patient days were unfavorable to budget by 578 for the month of October Three main contributors here were the ICU days were unfavorable to budget by 119 days or 24%. OB, PEDS, special care nursery, unfavorable to budget by 104 days. And adult med, surge days, unfavorable to budget by 297 or 11.1%. Our outpatient observation equivalent days were higher than budgeted by 74 days and are higher by 429 days on a year-to-date basis. The ALOS or the average length of stay or ALOS was positive, being lower than budget by 4 basis points. Next slide, okay. Case mix was slightly higher than budget for October at 1.587 compared to the budget of 1.530. Deliveries for the month of October of 121 were below budget by 8 and are 12 lower on a year-to-date basis. Total surgical cases in October were 480 and neutral to the budget of 480. Cath lab cases for October at 173 were below the budget by 47 or 21.4% and 88 below on a year-to-date basis. Non-emergency outpatient visits of 9,062 are above budget by 168 for the month and remain below budget on a year-to-date basis. Emergency room visits of 5,065 were slightly below budget by 54 or 1% and are 654 unfavorable on a year-to-date basis. The breakdown of surgical cases and cath lab cases. Overall in surgical, we saw favorable variances in orthopedic and neurosurgery at 17 and 6 respectively. This was unfortunately offset by underperformance in cardiac, vascular, and endoscopy and other surgeries. We were off by 47 in the cath lab cases on a budget of 220. And we saw unfavorable variances in peripheral, non-vascular, and neuro. Our productivity as an operating indicator, from a productivity standpoint, our blended productive FTE numbers were net favorable to budget by 10.6 for the month of October and by 4.4 year-to-date. October's blended non-productive FTEs were unfavorable by 28.6 for the month and 21.1 year-to-date. Total FTEs combined, that's the productive and non-productive for the month of October, were off by 18 and off by 16.7 on a year-to-date basis. Our total FTEs per adjusted occupied bed at 6.09 were 7 basis points favorable to the budget of 6.16. Next slide. Here on the summary of total deductions, our contractual allowance was favorable to budget by $6.5 million, despite a softer payer mix. And again, softer payer mix here just means a higher than budgeted governmental mix. Provision for bad debt and charity were also favorable to budget by $206,000 or 5.5%. This brings the total of the deductions to $151.2 million, which was better than budget by $6.7 million. However, actual deductions as a percentage of revenue stood at 76.61, which was unfavorable to the budget of 76.08. Now, the income statement from a GASB perspective, the Governmental Accounting Standards Board, gross patient revenues of $197.3 million were $10.2 million short, or 4.9% than budget, lower than budget. Our unfavorable payer mix was offset by supplemental revenues recognized during the month. However, deductions as a percent of revenue, 76.61, again, were unfavorable to the budget of 76.08. Our net operating loss for the month of October, it was $2.849 million and unfavorable to budget by $4.8 million. Operating expenses of $49.9 million for the month of October were $812,000 unfavorable, about 2% higher than budget. This was due mainly to higher salary, wages, and benefit costs, which combined were a negative $930 to budget. Our non-operating income or loss includes investment income of $782,000, property tax revenue of $1.4 million, and equity investment earnings of $244,000. This is equity or investment earnings is just the accounting recognition of a potential dividend from one of the JVs. These were offset by an increase in our interest expense of $226,000, which is a result of our recent bond issuance in August. And when in combination, these came up with a positive $171,000 in our non-op, thus making our total net income or loss for the month of October at a negative $2.68 million on a budget of a positive 1.95 for the month. $6 million loss year to date on a budget of a $433,000 net loss. Excuse me, $8 million. Now on the FASB, we do this, and as a reminder, unrealized loss on investments, net interest expense on GO bonds, and property tax revenues are removed from a FASB reporting income statement. So the total net loss for October was $4.18 million, or negative 10.1 on the margin, using FASB accounting principles, compared to the $2.7 million net loss using GASB. You can also see that our net income loss totals the 8869 on the FASB side and 7.995 on the GASB side. Next, we move to GASB on the EBITDA, earnings before interest, depreciation, and amortization. The EBITDA for the month of October was $398,000 on a budget of $5 million. While the year-to-date EBITDA is $4.5 million versus a year-to-date budget of $12.8 million, primarily due to lower volume, softer payer mix, and the expenses continuing to outpace the growth in our revenue. And with that, Mr. Chair, I'll stop my report.
Thank you, Tom. Any questions?
I'll go on to
Yep, go ahead.
I do want to just mention again that November is very preliminary. We're still working on the numbers, that want to give just an overview of where we stand at this point. So patient gross revenue of $190.6 million for November was unfavorable to budget by $10.3 million, or 5.1%, and lower than November of 2022 by 4.2%. Our inpatient gross revenue of $108.3 million was unfavorable to budget by $17.1 million and 10% lower than November 2022. And outpatient gross revenue of $82.3 million was favorable to budget by $6.8 million or 9% and 5% higher than November of 2022. I do want to just say we are including some graphs in this presentation just to show some perspective of over the last 12 months. So just to orient everybody to it, the orange bars are the actual inpatient, the green bar is the actual outpatient, and then you can see the budget total will always, and you'll see in other graphs, will be sort of the red dotted line. So you can see in terms of sort of over the last 12 months where we were or have been in terms of gross revenue compared to the budget. Again, the budget numbers are the dashed with the red. Moving on to key census statistics. Average length of stay of 5.03 was favorable to budget by 5.22, budget of 5.22 by 0.19 or 3.6%. It was just slightly higher than November's of 2022 of 5.02. We did in November have 5 discharges with length of stay greater than 30 days, and still in-house we now have 10 patients with length of stay over greater than 30 days. But I know that continue to look at the cases and see whether or not they're ready to transition to that next level. Also, outpatient observation equivalent days, 352 were unfavorable to budget by 274 by 78, or 28.5%. I do want to just say we do have a task force working on this to help ensure that patients are at the appropriate level of care. We've also started 5 West is going to be our dedicated for the majority of their OBS patients to be placed in that unit so that we can continue to monitor the time and the services that they need on a timely basis. So there's a large team that has been working on all of that. Inpatient average daily census of 155.2 was unfavorable to budget by 167.8 or 7.5%. And then the combined average daily census of 166.9 was unfavorable to budget of 176.9 by 10 or 5.7%. Again, next slide, you can see the 4 graphs here. Again, you just in terms of seeing, we have been, we've been in terms of length of stay, have been slightly bringing that down. I think it would be helpful maybe going forward also seeing sort of where having that line that shows in terms of how the trends are. So these are just showing the different trends for length of stay, outpatient observation days, inpatient average daily census, and then combined average daily census. Moving on to discharges. Discharges at 864 were unfavorable to budget of 965 by 101 or 10.5%. The main variance is due to procedure volume being the discharges being lower than that was budgeted by about 23.7%. Again, next slide, you can see the discharges trend in terms of we did budget for a higher level compared to last fiscal year in terms of it, but have not realized that in terms of the discharges. Moving on to patient days. Patient days of 4,657 were unfavorable to budget by 5,000, a budget of 5,035 by 378 days or 7.5%. Again, discharges were lower. Also, that contributes to this is our length of stay that was lower than budget. If you remember, it came in at 5.03. The areas that were unfavorable to budget, mainly the 2 areas were ICU days and also the OB, peds, and special care nurseries. There you can see again the trends, in red is the budget. Moving on to surgical trend, total surgeries in November at 457 were 19 or 4% unfavorable to budget of 476. and surgeries were 7.7% below November of 2022. Inpatient surgeries at 190 were unfavorable to budget by 16 or 7.8%, and outpatient surgeries at 267 were unfavorable to budget by 1.1%. Next slide, again, in terms of seeing the surgical trend and as it compares to budget over the last 12 months. Looking at the surgical activity, I do want to just say now, in terms of orthopedic surgery, we are now accounting for all orthopedic surgeries, not just the joints, because we had some that were down in other surgeries. So now this is all orthopedic surgery. So in terms of from that, the variance from budget for orthopedic surgeries is 11. Neurosurgery was down compared to budget by 5, and cardiac surgery was down by 6. We have, in terms of continuing to focus on cardiac surgery, and you heard in terms of we are starting TAVR. We did do 3 TAVR patients today. We did not, we started back up in terms of working with the physicians, and I know that we have about 7 cases that are scheduled for the month of December. Other areas, vascular surgery, we did just bring on another vascular surgeon, so we should be seeing over time that volume increase. Endoscopy is down a little bit. We do have one of our endoscopy physicians that is out on maternity leave. Moving on to cath lab cases for November at 150 were 38, unfavorable to the budget of 188. Inpatient cases at 86 were 21 or 19.6% unfavorable to the budget of 107. And outpatient cases at 64 were 17 or 21% unfavorable to budget. Again, in terms of seeing the trend, really trying to build back up, that's one of the areas that we're focusing on with working with our interventional radiology physicians, IR physicians, also our cardiologists and vascular to build up, once again, the cath lab volume. You can see in terms of the cath lab activity as it's broken down, our cardiac cases were under budget by 15. Peripheral vascular cases, that's mainly a lot of our IR cases, were down by 20. We did have one of our IR physicians was not available a number of the time in November, so working on again, continuing to look at the IR cases and growing those. Moving on to deliveries for the month of November, we were down 30 deliveries in terms of that. Our volume, as you can see, continues to go up and down in deliveries. It was unfavorable to budget by 30 or 20.5%. Year to date, our total deliveries is 621. This is unfavorable by 6.3% to budget. So we were right on, and I know we were down for this month. And you can see on the next page here, you can see in terms of our deliveries, they do continue to be up and down in terms of each month. Moving on to our non-ER outpatient trend, non-emergency outpatient visits of 8,724. Non-emergency outpatient visits were favorable to budget by 5.3%. This was really driven by a couple of areas. Imaging services were favorable to budget by 19.6%, cardiac rehab by 27.3%, and also our prenatal diagnostic center visits were 39.7% over budget. And you can see on that next page the trend. Moving on to emergency room visits, we were very close to budget in terms of coming in at 4,959. We're favorable to budget by 6 or 0.1%. And if you want to turn to the next one, you can see, again, in terms of our trends, We started off a little bit in July, a little bit lower, but have continued to be close to budget in terms of the last few months for our emergency room visits. Looking at our gross revenue recap, it is aligning with the areas in terms of being down. Our surgical cases were 4% less than budget. However, revenue was 15.3, and that's really driven by the case mix of our surgeries that were under budget, including cardiac and neurosurgery that were under budget. Again, cath lab revenue was revenue is below budget by 28.2%, and the cases were unfavorable to budget by 20.2%. In terms of room and board and ancillary, you can see it's 0.7% below budget, and then deliveries, with that being below budget, is also the revenue is below budget by 23.8%. And lastly, emergency visits were favorable to budget by 4.8%, which also the revenue was favorable to budget given where we stood with the visits. Our payer mix, again, continuing to see more of our government-sponsored than what we've budgeted. For government-sponsored, it came in at 72.9% compared to a budget of 71.8%. You can see HMO came in at 2.5% versus a budget of 2.3%. PPO was down at 22.3% versus 24.5%. We are looking more into this in terms of our payers. I think the other piece from what I'm hearing from some of the other hospitals in the area is we are seeing, as we know, that a lot of the tech companies had layoffs, and it takes us a lot of times 4 to 6 months to feel that. And I know some of the other hospitals have said they've seen some of that impact too. So we are looking more into that. And then private pay was 2.3% of gross revenue, which was unfavorable to the budget of 1.4%. And we did have a number of accounts that were from out of the country that exceeded $1 million in terms of that. So, and again, you can see in terms of the preliminary payer mix and where we stand, and you can see that we have seen some definitely growth over the last 12 months in our government-sponsored payer mix. Preliminary productivity indicators. Our productive FTEs were favorable to budget by 91.6 or 6.2% at 1,377.2. Non-productive FTEs were unfavorable to budget by 21.3%, and total FTEs of 1,632.3 were favorable to budget by 46.9 or 2.8%. So it really did focus on looking at flexing in terms of our FTEs. Total FTEs per adjusted occupied bed came in at 5.97 and was favorable to the budget of 6.25 by 4.5%. So it is an area that we continue to work on. In terms of other preliminary outpatient statistics, in terms of our Whitmouth clinics, down 10.9%. A lot of that, 12.4%, or the majority of it is in primary care. We really have a number of open positions in primary care that we are in the process of trying to recruit for. We have one at Civic Center, pediatrics, there's a couple in Civic Center and pediatrics, and so that's been a challenge for us in terms of bringing in primary care physicians. In terms of specialty care, they were down by 9.3% or 772 visits, and that was also, we have an open position in psychiatry and orthopedics, and vascular is just in the process, as you know, brought somebody on in October, and they are building their panel of patients. Moving on to DevCo, overall we were down 11%. That's really driven the majority by our outpatient rehab center. We, again, as you can tell, when we have staffing issues in that, we really see that drop. We did have one full-time physician, PT that was on leave, and then we had also a number that were off in November. So that was really focused on our staffing. And then lastly, you can see Radiation Oncology Center was down for the month. This was driven by one of our medical oncologists being on leave, so reducing in terms of the number of referrals. However, in December, we do see referrals and treatments are tracking higher. There were 21 new patients, 29 referrals, 16 new treatment starts. We also did finally start, we have the new CT scanner that was finally approved by the state, and that started up in November 29th, and we also have 10 patients that are awaiting scheduling. So I know that our medical oncologist is back, so we're starting to see that move forward. Moving on to our financial statistics, days cash on hand, we did drop 1 day. We did have 3 pay periods, which was the main cause of this. I do want to just recognize our revenue cycle group. Our days in AR came in at 55.9. That is the lowest. We have, as you will see on the next slide, that is the lowest that in the last 12 months that we've had. And so they've really been working on this, and I just do want to thank them for all their hard work. It really is a huge team effort. And also then Charity Care came in below the prior month at 141,810. So you can see our days, our goal is to get our days back up to 150. It's going to take a little bit of time, but that is where we need to be. But again, our days in AR, I should say days cash on hand, but then days in AR has really been moving in the right direction. And that is the preliminary results for November. So we know we've got a number of areas we need to work on and focus on, not only in terms of expenses, but also in terms of revenue. The chart's helpful, okay, yeah, just to show a little bit.
It's nice to see that historical.
Yeah, so to
and
see.
And it's nice to see the budget as a red line there, so we can,
right.
easy to
so
see
you can
visually
see,
comparison.
yes, I mean, I think one of the things is, as we've said, we've budgeted higher, and especially in the revenue side, but it is around the same as what we've been seeing over the last 12 months. All right, should I move on to Employee of the Month? And so we have 2 this month, because if you remember, we have both November and December. So I want to start with November Employee of the Month. It's Madhav Bhatt. He's the Senior Application Analyst for Information Services. Madhav and his Enterprise Analytics team are able to measure trends in our healthcare system, including the busiest times of day, how many days it takes for a patient to be seen, and the best patient outcomes. In 2013, our healthcare system began the process of implementing Epic for electronic medical record system and many other applications. Madhav worked as a contractor full-time for Washington. In 2019, he became part of the official employee of the IS family, joining the healthcare system. Washington Hospital participates in the state of California's Quality Improvement Program. This program provides financial incentives for hospitals that meet specific state-required measures. Madhav has played a really important key role in developing the framework to gather and analyze the data. This ongoing project requires precise analytics and teamwork. Our organization has successfully been able to demonstrate that we meet or exceed those measurements, and he has played a big role in this. Having studied in India, Madhav holds a diploma in Information and Systems Management, an MBA in Systems, and a diploma in Medicine and Surgery from State Directorate of Medical Education and Research. Early in his career, he worked as an intensivist in critical care units, and later as chief coordinator of a hospital's information systems department, providing his connection to the healthcare industry. One of the things about his work that Madhav most enjoys is the connection between data and the patient-first ethic. He says the work we do enables better patient care because we contribute to the efficiency of care providers. While we may not be at the bedside providing care, we help those who are. Madhav lives in Mountain View with his wife and daughter. He enjoys reading about archaeology and history and enjoys traveling, including a recent trip to Alaska. So we're very fortunate to have Madhav as part of our IT team. So yes. All right, moving on to then our December Employee of the Month. It's Jasmine Land. She's a clinical pharmacist who was raised in Minnesota, received her master's degree in organic chemistry from UCLA, and completed her PharmD degree from UCSF. Jasmine completed her residency at Stanford Health before beginning her career at Washington Hospital in 2008. She was part of the first group of emergency department clinical pharmacists and passionately worked in our ICU ED units for over 6 years. She moved out of the area for a year, but her heart remained in the Bay Area. When she returned, she accepted a managerial role with another healthcare system, but when she learned that a per diem role was available at Washington, she agreed to return for our Saturday shifts. Since 2015, on Saturdays, Jasmine has been working diligently under our care team-based model in the ICU and the ED. She collaborates with nurses and physicians to provide quality care. Over the years, many examples have been cited of Jasmine going above and beyond to provide the best possible patient care. She recently worked with a patient who was unable to pay for a high-priced insulin medication. After phone calls to several pharmacies, Jasmine was unable to find a more affordable option. While many clinicians may have conceded, Jasmine consulted with a physician to determine that an alternative, more affordable option would work. She dedicated several hours, which resulted in one patient feeling cared for and understood. When she's not working, she enjoys many activities, including tennis, spending time at a shooting range, and being a dog mom to a Yorkie and a Shih Tzu. Congratulations, December Employee of the Month. All right, we're getting there. I just will go through the calendar for the past promotion events. I'll just hit some of the highlights of this. I also want to say, I know many of you, Angus Cochran had presented the community needs assessment, and he's been presenting it to other places. So I know they're going to bring up the calendar. So on November 3rd, Special Olympics, we were present, and the athletics trainers provided on-site first aid to over 354 athletes participated. Again, November 9th, Newark City Council, Angus Cochran presented the results of the community needs assessment. You can see that also Lena Huang did a diabetes presentation on Facebook Live and YouTube, over 51 live views and 345 accessed it later. You can see that we hosted on November 13th the American High School Future Health Professionals Club. Moving on, Angus also on November 16th presented the findings of the community needs assessment at Union City Family Center Collaborative Partnership. As we know, there were a number of areas that we want to focus on in Union City. November 17th, Glenmore Elementary Health Fair, the Medical Foundation provided health education on hand washing. November 28th, our Dr. Surya palliative care physician provided information on understanding palliative care on Facebook and YouTube. Dr. Joyce Liu is our new vascular surgeon. She presented at Acacia Creek on November 30th. Also on November 30th, Dr. Kern presented on medical careers at the Irvington High School PTSA. Moving on, as we know, there was a tree lighting on December 1st that we participated in with health education. Also hosted our tattoo removal program on December 2nd, and on the 5th, one of our new OB physicians, Dr. Mather, presented on pregnancy after age 35. And lastly, we had a very successful tree lighting celebration in Anderson Auditorium on December 6th. You can move through those pictures and see some of our participation in the health fairs. These are two of our upcoming health promotion events. Dr. Seema Sehgal, a psychiatrist, will be presenting on Facebook Live on the 18th, and on the 21st, we will be participating at the Kitayama Elementary School Health Fair. And just as mentioned, on December 6th, we had very fun and festive holiday tree lighting, and want to thank everybody who participated. We had over 200 community members that did, and Supervisor Marquez presented a check for $10,000 for our Service League's Wolf Canine Therapy Program. And so we're excited about that. Also, for Giving Tuesday, we did raise $7,000 that will go towards our trauma education and training program. That is the calendar for November and December.
Thank you. Do you have one more action
Yes,
item?
exactly. Thank you.
Are you ready for that, Mr. President? This is item B. Mr. President, I move that the Board of Directors authorize the Chief Executive Officer to proceed with entering into a contract with Local 20 to negotiate the wages, hours, and working conditions for the utilization review coordinators.
There are 7 employees that are part of this that they've petitioned and voted, and so we're moving forward. Yes.
Kishore, can you have a roll?
Yes. Director Epen,
Aye.
Director Stewart,
Aye.
Director Wallace,
Aye.
Director Nicholson,
Aye.
Director Yee.
Aye.
All right, any more announcements?
Nope, that was it. I appreciate, I know we had a number of presentations, but overall, we had some very good ones too.
Yeah.
Yes.
Being no further business, the meeting is adjourned.